How about the differential for acute epididymitis? It can be difficult sometimes to associate from torsion. And you say, how could that be? Well, acute epididymitis can come on relatively rapidly, which is why sometimes torsion enters into the differential. And people who have tumor can also have concurrent inflammation associated with it. So anytime you have what looks like a focal abnormality in the testis, which might be orchitis, think in the back of your mind, could it possibly be a neoplasm? And if a patient is being treated for epididymitis and there's associated, quote, orchitis, make sure you follow that patient to make sure what's in the testis improves or goes away with therapy. Let's discuss torsion now. An important entity tends to occur in fairly young men who have a predisposing congenital abnormality of the way their testis is invested in their scrotal sac. Normally, as the testis descends and it comes from the high retroperitoneum into the scrotum, it pushes the associated peritoneum in front of it. And for some reason, instead of calling it the peritoneum, we've already mentioned the tunica albuginea as being the surrounding structure at the periphery of the testis. We now call the peritoneal surface as it enters into the scrotal sac the tunica vaginalis. That is just the associated peritoneum that's come down through the inguinal canal in utero and is in front of the testis, because the testis normally is invested and is sealed down at the level of the epididymis with the tunica vaginalis or peritoneum in front of it, but not all around it. An abnormal investment is when the tunica, when the testis, as it comes down into the scrotal sac, is completely surrounded by the tunica vaginalis. It's almost analogous to putting your hand into a sock. That would be the testis, surrounded by the tunica vaginalis, or the peritoneum completely surrounding it, and not having a solid attachment, if you will, of the epididymal level into the scrotal sac. So here we have a large hydrocele, but notice this patient's lying on their back, and the testis is here, but there's no fluid behind it. Well, why is that? You would think with gravity there should be fluid behind here, but there's not, because at this level, which is the level of the epididymis, there is a solid attachment of the scrotum and epididymis to the scrotum itself. So there's no fluid behind it. Here, however, we have a sagittal and transverse scan. This is a neonate, and I'm going to come back to this patient, but I'm showing you this because no matter where I went, there was only a small degree of attachment of the testis. Otherwise, it was free to rotate, and that's known as the bell clapper deformity. This would be analogous to the testis here, minimally attached, free to rotate on its axis, the classic bell clapper deformity. So when you have somebody with a large hydrocele, look around and make sure that you can see that firm attachment. Failure to see that puts that patient at high risk for a torsion. Well, what are the features of torsion? Obviously, it's acute pain, and most people will come to seek help rather quickly, within about 6 hours, following the onset of their symptoms. And if we can operate in that golden period, which is considered about 6 hours, often the testis can be salvaged. The epididymis is typically enlarged, and the testicle may have a normal or an abnormal appearance. And typically, when it's abnormal in appearance, that means you're beyond that golden period where you can salvage the testis. The other findings, including skin thickening, hydrocele, epididymal enlargement, none of these findings are specific. So how do we make the diagnosis? Well, first, what does it look like? 3 different patients. Asymmetry is what we see here. In the first patient, the right side was the symptomatic side. Notice the skin thickening, not a specific finding. And not surprising, once the testis does not have an appearance that is similar to the normal side, that is often seen in a non-viable situation. That patient required orchiectomy. Here we see, again, asymmetry, but in this case it was the left testis that was symptomatic, and I'm showing you this case to show the dramatic difference in echogenicity between patient 1, which was hypoechoic, patient 2 was echogenic, and in this case it was a non-viable left testis, which was very hyperechoic. And in this case, they both look the same. So which is the abnormal side? I don't know based on imaging, but clinically it was this side, and this patient had a viable testis. Well, how am I supposed to tell you that was viable? How would I know? I can't tell on grayscale because it's similar to the opposite side. Obviously, the answer is with torsion, you want to look at the blood flow. If the testicle especially has normal echogenicity, there's a good chance there may be a viable testis. Here there's a heterogeneous testis. On the symptomatic side, there's no blood flow. Not surprisingly, that's non-viable. If you're entertaining the diagnosis, similar to what we do in women, looking for the so-called whirlpool sign or twisted area where the ligament leads into the ovary, looking for the twist, you can do the same thing in a man. You come up at the inguinal level, and you can see, this case was done by my colleague when I worked at the Brigham Hospital in Boston. This was done by Rusty Brown. You can see a whirlpool sign here, or a twisting of the testicular artery. And there we have a case of a viable but torsed inguinal testicular artery at the level of the inguinal canal. Now, remember I showed you a bell clapper. I said it was a neonate. This is actually a newborn baby. I was on call. I was asked to look at this newborn that had a purple scrotum bilaterally. And when I looked at this newborn, I noticed the bell clapper, which I've already alluded to, and this testis had no blood flow and was heterogeneous, clearly abnormal, and I suggested that was an infarcted testis on this side. So what did I do at this point? Well, this testis is not going to work for this neonate, and unfortunate, but that's what sometimes happens. I put color on, and I was surprised to see how much blood flow there was in the testis with the bell clapper type of deformity. But I am not a pediatric radiologist, and I was unsure if this was normal. I suspected this was hyperemic and increased flow. Well, how was I to prove that? Well, what I actually did was I said, I think it's too much flow. I actually went to the next neighboring little boy baby in the neonatal area, and I looked at his testis, and there was only a small amount of flow, so I clearly knew this was hyperemic, and what I suggested then was that this was a detorsed testis that was now hyperemic because of what we call a missed torsion. What do you do when there is a missed torsion or a detorsion? You get on the phone immediately and you call the physician who's taking care of this baby, because this baby needs to go to the OR right now, because we've already known that the other testicle was infarcted. If he torsed this testis and lost this testis on day 1 of life, he would have no testicular function, and that was what was proven at surgery.